Michelle.
All right, good morning, everyone. Today, I'm very pleased to have Dr. Jennifer Charlton here to kick off our grand rounds for 2021. Dr. Charlton is an associate professor in the Division of Pediatric Nephrology at the University of Virginia in Charlottesville, and her research focuses on the effects of preterm birth on the development and long-term function of the kidneys. She's a founding member of the Neonatal Kidney Collaborative, which is a really great national organization that aims to improve outcomes for children with prematurity as far as their kidney function goes. She did her residency at the University of South Carolina and her pediatric nephrology fellowship at UVA. And I'm very happy to have you here. And welcome, Dr. Charlton.
Thank you so much. I am ecstatic to be able to give grand rounds, not only in the comfort of my own home in January, instead of at Minnesota, although I am sad to not be able to chat face-to-face with you guys. So this is my disclosure slide. I am going to be talking a little bit about caffeine as an off-label potential use for abrogating acute kidney injury in neonates. The outline of my talk includes the long-term outcomes after premature birth. I'm going to talk a little bit about unique factors in life-saving therapies in the NICU that may affect the kidneys, specifically talk about neonatal acute kidney injury in the context of the Neonatal Kidney Collaborative and its association with CKD. I'm going to talk a little bit about some animal models and recommendations for follow-up. And I changed my slides last night, so I'm going to talk about the detection or follow-up first and then detection of CKD. As you guys are well aware, prematurity is not an uncommon event, with 15 million babies born premature around the world. And in the United States, many of these infants leave the NICU without significant neonatal morbidity or mortality. And we are now down to 22 weeks of gestation as a viable gestational age. But what happens to these kids' kidneys? In epidemiologic studies, we've seen a signal. We've seen a signal between low birth weight or less than 2.5 kilos and based off of birth weights of less than 1.5 kilos, that there is an association with chronic kidney disease. This is detected both in adult epidemiologic studies, and now we have seen it in when we look at children also. So I want to pause for just a second and remind the neonatologists, especially, and the pediatricians, that chronic kidney disease is a three-letter word that is bad for you, or CKD is bad. CKD at any stage results in higher risk for death, cardiovascular events, and hospitalization. So it's really important that this long-term outcome be appreciated and incorporated into the follow-up for these children. And I hope over the next hour, I'm going to convince you that premature infants are at risk for chronic kidney disease. And just as a reminder, chronic kidney disease is very common in adults. 1 in 7 adults have chronic kidney disease, and many of them don't even realize that they have it. And although diabetes and high blood pressure represent the majority of those reasons for end-stage renal disease in the United States, there's still a large percentage of either unknown causes or other causes for end-stage renal disease. And I would also say that people that have a low nephron number from prematurity and then develop diabetes or high blood pressure, that prematurity or low nephron number to begin with may be a precursor before their development of diabetes or high blood pressure. And so the way I think about chronic kidney disease in its most basic form is that there's just too few nephrons to do the work of the kidney. And what do we know about nephron number and what is too few nephrons? And this will play into how we think about prematurity in just a second. So when I teach the medical students about nephron number and about kidney development, I tell them that on average, people have about 1 million nephrons per kidney per individual. And on average, on population-based statistics, that is correct. However, look at the x-axis of this graph. The range is quite wide. Anywhere from 200,000 nephrons to 2.7 million nephrons has been observed in humans that aren't known to have overt chronic kidney disease. These are the 3 studies on the left that have really elucidated the number of nephrons. And the largest study done by John Bertram that covered many ethnicities, races, and ages showed that in this study of 400 patients, 900, the average nephron number was about 900,000. So a little bit about nephrogenesis and a little bit about how these nephrons are formed. Nephrogenesis in humans begins at 9 weeks. It's completed at 36 weeks. So this is important. At 36 weeks, at full term gestation, a human has every nephron it's ever going to have for all of its life. And so it's really only downhill after you have gotten to your nephron endowment, which happens at 36 weeks. And the 3rd trimester is an incredibly important time for kidney development. 60% of nephrons are formed in that 3rd trimester. 60% of those nephrons happen at the very end. So our organ is a very late branching, it's a branching organ that develops very late in gestation, similar to the lung, but we don't have the same manifestations after birth that the lung may have. This box highlights the number of nephrons that is formed from the time of viable gestation at 22 to 23 weeks until term. And nephrons can't regenerate. Once you have lost a nephron, once it is damaged beyond repair, it is gone and cannot regenerate. And nephron number gradually declines over time. So by the age of 30, you start losing glomeruli over time. And that is why most of the time dialysis units are filled with older people, that they have lost enough nephrons that they don't, they've run out of their supply of nephrons. So what happens to premature infants? Do they stop making nephrons as soon as they are born? That's not true. We think that they probably do make nephrons after they are born. However, that in ex utero environment is a highly abnormal environment for making nephrons. And these 2 studies done out of Miami and out of Australia show that the layers of glomeruli, the kidney develops from the inside out. The ureteric bud invades the metanephric mesenchyme, and that metanephric mesenchyme are self-renewing progenitor populations that end up making a glomerulus at the tip of each of those ureteric buds. And so the kidney forms sort of like rings, sort of like a tree with rings and layers of glomeruli. And so in the study done by the Miami group on the left, they showed that those layers of glomeruli, that there were fewer of them in those premature infants. But they did show evidence of glomerulogenesis after those babies were born up to 40 days after birth. And so if you do the math, if you take a 24-week gestational age infant and you get 40 more days, that's about 6 more weeks of nephrogenesis. And so they really only get to about 30 weeks of nephrogenesis, where I said earlier that 36 weeks is the time that it should end. And so this is an abnormal situation where we may make new nephrons and in that ex utero environment, but they're often abnormal. And here you can see from the histologic section that these glomeruli on the very outer cortex, on the very outer rim under the capsule, which are the last to be formed, are the ones that are probably the most vulnerable to those differences in intrauterine versus extrauterine environments. So there are many unique factors in the NICU that predispose these infants for abnormal nephrogenesis and fewer nephrons. And so I'd like to introduce a 7-year-old, he was 7 when he presented to me, who presented to his pediatrician, who had very normal, or had sort of on the small side. His blood pressure was generous, and when they did a screening urinalysis on him, he had 4+ protein. And when they did further labs, showed that he had chronic kidney disease, and he had really nothing in his history except that he was born at 24 weeks. And so over here, I try to highlight some of the abnormal pieces and parts of NICU courses that can affect nephrogenesis. So as I had shown before, human nephrogenesis ends at 36 weeks, but as we talk about some of the animal studies that I'm going to highlight in the next couple slides, I want to remind you that nephrogenesis is variable depending on species. So in humans, nephrogenesis ends at 36 weeks, so it ends at the end of gestation. But in mice, nephrogenesis continues for a window of 4 postnatal days after birth. The baboons are more like humans. They end nephrogenesis at full-term gestation. Rats and rabbits are more like mice in that they have a window of postnatal nephrogenesis that's normal and natural and occurs in an ex utero environment. So some of the things that are absolutely life-saving for these infants but can affect the kidney are, number one, oxygen. So in this study of rat pups, they were exposed in that window of nephrogenesis, postnatal nephrogenesis, to high oxygen contents. And as they grew up, they had higher blood pressures, they had a decreased capillary density, and they had fewer glomeruli when they evaluated them as adults. There are a lot of nephrotoxins, nephrotoxic medications that are given to these infants. Again, these are life-saving antibiotics and medications that premature infants may need. The risk of these medications may outweigh or may be lower than the benefit to these infants at the time that they are given. But aminoglycosides given to pregnant rodents, so in a period of intrauterine nephrogenesis, reduce glomerular number by 25% in the pups. And these non-steroidal and non-steroidal drugs, when given again in that postnatal window to rats, reduce their nephron number. So these all may contribute to the depletion of nephrons in these vulnerable infants. The last part of the unique exposures that I wanted to highlight is the natural and normal immaturity of the proximal tubule. So in utero, a fetus does not use their kidneys quite the same way as they do ex utero. Really, the excretory organ of the fetus is the placenta, and mom basically does dialysis for her fetus in utero. And so the kidneys don't have to be really good at reclaiming things, and their GFR does not have to be very good for filtration. And in utero, there's a closed circuit. So fetal urine turns into amniotic fluid, which is sucked, swallowed, and breathed back down to the fetus. And everything that comes out of the infant gets recycled in this closed environment. However, in an ex utero environment, again, the kidneys are very immature. They do not have the same reabsorptive capacity, but now there's no placenta and there's no amniotic fluid being recirculated to keep the things that they are not reclaiming back in their circulation. We found, we recruited a patient population from 28 to 40 weeks over the gestational ages of 28 to 40 weeks, and looked at the urine of these infants and found that they had high levels of retinol binding protein, the binding protein that carries around vitamin A, and high levels of vitamin D binding protein that carries around the vitamin D, and that those urinary binding proteins decreased over the gestational age from 28 to 38 weeks. And what we realized is that these and many other of the urine proteins that we found in the urine of these premature infants were actually megalin ligands. So megalin is located in a lot of different places in the body, but mainly in the kidney. It's in the proximal tubule, and it acts as a vacuum sweeper in the proximal tubule to reclaim a lot of these biologically important proteins, and especially retinol binding protein and vitamin D binding protein. And so when we found these very high urinary levels of these megalin ligands, we went back and got tissue samples from premature infants that had passed away within the week of their gestational age, of the week of their birth. And so we categorized these babies across the gestational age, or these kidney samples across the gestational ages from 20 to 40 weeks. And we stained with a lotus lectin marker, which is a marker of mature proximal tubules, and then with both megalin, retinol binding protein, and vitamin D binding protein. And you can see the big difference between the 21-week on the top of this graph and the 40-week fetus of the expression of these markers. And then we correlated between the alive babies, the previous cohort that we looked at their urines, and this cohort of autopsy tissue samples, and showed that there was a pretty significant inverse correlation between how much tissue megalin we saw expressed in the kidney and how much urinary wasting of these ligands that you had. Accentuating the fact that these immature kidneys may be wasting things that are biologically important. This impact of this developmental proteinuria may play a role with the high prevalence of vitamin A deficiency in premature infants and vitamin D deficiency in these infants, and may actually have an impact on nephron number itself. So in this rat study, they correlated the plasma retinol levels or vitamin A retinol levels with nephron number, and showed a very striking correlation between vitamin A deficiency and nephron number in these rats. And that vitamin A in previous studies has been able to restore nephron number in offspring that have been exposed to protein restriction. So moving on into the category of acute kidney injury, I'd like to give you a little bit of history about the Neonatal Kidney Collaborative and the studies that we have done moving forward. So in 2013, the NIH sponsored an AKI workshop. They invited neonatologists and nephrologists from around the United States to come discuss the multiple gaps in knowledge surrounding acute kidney injury, and put us all in a room together to discuss this important topic. From this, the Neonatal Kidney Collaborative was born, or was conceived. The Neonatal Kidney Collaborative is a group of neonatologists and nephrologists with a mission to improve the health of neonates that are at risk for kidney disease. And in this study, or in this collaborative, the very first study that we did, our first mission, or our first objective was to do a retrospective study to look to see what it was happening in our NICUs at the time. So in this study that we termed Awaken, 24 sites, each with a neonatologist, each with a nephrologist, and with no money, gathered data on approximately 4,000 infants. We screened 4,000 infants over a 3-month period in this retrospective design, and ended up enrolling high-risk individuals. So really, we eliminated, many NICUs had kids or infants that we felt were not really at high risk for acute kidney injury, and used this IV hydration status, or the need for IV hydration for less than 48 hours, to exclude a large portion of the screened individuals, thinking that it'd be highly unlikely that those infants would develop acute kidney injury. So in the end, we enrolled nearly 2,200 infants into this retrospective study. Again, it was a multi-center retrospective cohort study that included 24 sites. I will say from around around the globe. We had one Australian site and one Indian site, but most of the sites were from the US and Canada. And we included all NICU admissions from January 1st to March 31st, and this is from 2014. So our data is starting to get a little antiquated at this point. But this is not a representation of all NICU babies. It's a representation of sick or vulnerable NICU babies. And again, these are the numbers that we screened, enrolled, and had sufficient data on about 2,000 infants. 160 infants approximately did not have enough data to say if they had acute kidney injury by either urine output criteria or by serum creatinine data. Of the enrolled infants, 30% of these infants had acute kidney injury. So our first hypothesis was neonatal acute kidney injury was independently associated with short-term risk, such as mortality and length of stay after adjusting for confounding variables. Many single center studies had shown this. However, this is the largest study across all gestational ages to be able to look at this. So we categorized each of the, we stratified each infant into one of three categories by gestational ages. And our largest gestational age group was this middle group of 29 to 36 weekers. And then we had the smallest gestational age group, almost 300 infants in it. When you broke down these categories as to who had acute kidney injury by gestational age, it was not surprising that both the smallest gestational age group had a large proportion of their infants exposed to acute kidney injury, and the sickest term infants also had a large proportion. I want to highlight the proportion though of, or the percentage of infants that had acute kidney injury in the 29 to 36 week group. This group we often think of as a very stable and not very sick necessarily gestational age group. It's a very large group in our study in most NICUs. But nearly 20% of these kids had acute kidney injury. This is a population that has not been studied very well and really deserves a closer look. So when you look at the mortality rates of these infants, we showed that the risk for death in these infants was higher if you had acute kidney injury. And even when you adjusted for all of the things that can lead to death in this highly vulnerable patient population, acute kidney injury was still independently associated with both mortality and with length of stay. And this is overall, this is the whole group, any acute kidney injury at any point during their time frame. What we realized really early was that basically by our definition, and because neonates are harder to classify by acute kidney injury, there was probably two different types of acute kidney injury that may be happening in these kids. And started to look at this patient population by the timing of their AKI. And we deemed early AKI as being less than 7 days after birth, and late AKI being greater than 7 days. Because really, the early factors that led to AKI were very different than the late factors in our thoughts. And the late AKI was a lot easier to classify using the neonatal KDIGO modified definition because the definition is based, has a baseline serum creatinine. We all know that the adjustment of serum creatinine, or the flux of serum creatinine in that first week is challenging to deal with because you start with moms, and many of these very preterm infants have a small rise in their serum creatinine just after birth. And so it makes it challenging to deal with. So when we started to look at the risk factors that led to acute kidney injury, we ended up dividing up our risk factors into early risk factors and late risk factors. And so we published 2 publications out of this. But the first thing that we had to do, so in the first study, looking at the early onset neonatal acute kidney injury in this AWAKEN cohort, the first thing that we had to do was show that early acute kidney injury had an impact on both mortality and hospitalization. That had not been shown. Really, in all the other smaller studies, we had looked at acute kidney injury across the whole spectrum in the NICU. And so in this study, we showed that acute kidney injury in the first week was still independently associated with mortality and hospitalization, and that there were certain risk factors that were associated with increased risk. Some of them were a surprise to us, and they weren't surprising. The transfer of them from the outside hospital was not surprising to my neonatology colleagues. They say that is a risk factor for every short-term outcome. But things like high bilirubin and the inborn errors of metabolism were a little more surprising to us and really need to be looked at more carefully. What was not surprising, but was challenging, was the frequency of serum creatinine monitoring throughout the 24 sites. We had some sites that were very frequent monitors, and we had other sites that were very infrequent monitors for serum creatinine. And obviously, if you're not checking serum creatinine, you're not going to catch acute kidney injury, as that is how it is defined. There were a couple of things that were associated with a decreased risk of acute kidney injury in this early population. We broke the population down by gestational ages and looked at the risk factors that increased or decreased risk for acute kidney injury in that early population. And then we took a look at the late risk factors, or the risk factors for late acute kidney injury, and again showed that there was an independent association between acute kidney injury and death and length of stay if you were in that late category. And interestingly, the exposure to nephrotoxic medications in the early risk for acute kidney injury was surprising, that nephrotoxic medications were associated with a reduced risk in the early population. They were associated with an increased risk in the late acute kidney injury population. And I think that is partly due to the majority of kids get nephrotoxic medications in that early course, and it was hard to statistically separate those out. So moving forward, our group and others have looked at the protective effect of caffeine in acute kidney injury. You guys are all well aware that caffeine is used quite prevalently in the premature population to reduce apnea of prematurity. And with that in mind, there have been several studies of other adenosine agonists that have been used. And in fact, in the KDIGO criteria, in the KDIGO guidelines for acute kidney injury, there is a line in those guidelines that says if you have a baby that has hypoxic and severe HIE as they come in, a dose of theophylline, which is another adenosine agonist, can be used to help reduce acute kidney injury. And that comes from several randomized control trials that have been used to show that theophylline as a medication has helped babies with HIE continue to have better urine output and better GFRs. And so we looked at this data in the Awaken database to see if that association between caffeine and acute kidney injury held as it has held in smaller single center studies. We divided the subjects up into the extreme prematurity group, the 22 to 28 weeks, and then the 29 to 33 week group. And when we tried to publish this initially, we were told that your association is only because babies that get caffeine are healthier, babies that get caffeine are less likely to have acute kidney injury. But that was actually not true. And we showed that the babies received caffeine quite early, they were quite sick, and they were actually sicker than the ones that didn't receive caffeine. We show here in this Kaplan-Meier curve the protective effect of AKI survival, AKI-free survival in those that have gotten caffeine versus not gotten caffeine. And here, the number needed to expose is quite low to protect against an event of acute kidney injury. Caffeine is not currently being given as a protective agent because we need prospective studies to see if it actually works as a protective agent. And there are some challenges with clinical trials, as this is such a prevalently used drug for other purposes. So from Awaken, we've answered a lot of questions. We can say that in high risk or more vulnerable the NICU population, 30% of patients develop acute kidney injury, and both early and late are associated with increased risk for death and longer lengths of stay. The biggest thing that came out of, I think, the risk factor paper is the huge practice variation for screening for acute kidney injury, that we have no standardized guidelines for monitoring, and that impacts if we're using the right definition for acute kidney injury. And we have lots more questions. And as of August, we've published 14 papers out of this cohort. We have multiple more. We have 2 abstracts that we submitted to PAS yesterday, looking more at the nephrotoxin burden in this patient population. And we collected information on discharge summaries out of this patient population. So if you're interested, I'm going to give you a plug for visiting this website. The Neonatal Kidney Collaborative has its own dedicated website. We have now branched out into not just being one research study, aka the Awaken study, but we now have 4 arms of our organization. One arm is the research arm. It's still actively doing secondaries from Awaken. We are proposing a prospective multi-center observational trial that's called Arising, that is being worked through the NIH currently. We also have a Twitter handle, so if you're interested in following us on Twitter, that's our handle. Besides the research committee, we have a very active education committee, and we have a very active advocacy and communications arm. We are doing Twitter journal clubs and lots of other stuff, so join us and follow us. So does acute kidney injury in the NICU really lead to chronic kidney disease? And this is where we have some less knowledge. There's really just 2 studies, 2 to 3 studies that have looked at AKI as a risk factor for chronic kidney disease in infants. And the first one was a French study done as a matched study with a smallish number of enrollees that were studied at 6 years. And they used a different definition of acute kidney injury that was based off of gestational ages. But overall, what I want to highlight out of this is that whether or not you had acute kidney injury, this study showed that 23% of their cohort already had an abnormal GFR at the age of only 6 years. An absolutely wonderful fellow, while he was here, did this study with us, a prospective cohort study looking at those with acute kidney injury and not acute kidney injury in the very low birth weight neonates. He showed that if you were a very low birth weight neonate that was exposed to acute kidney injury, you had a 4.5 times higher risk of having either a high blood pressure, protein in your urine, or a abnormal GFR. So really more work is needed in this space. And as these infants born 22, 23, 24 weeks grow up, there will be more need for follow-up. So that leads into the next section of what should we do for these kids once they leave the NICU, and how should we approach them? This child was born at 24 weeks. He had a lot of exposures to nephrotoxins and had a very significant acute kidney injury, but yet there was no follow-up for him in the nephrology clinic. So what do we know from what standards or what guidelines do we have for follow-up after acute kidney injury? Really, we have basically 2. The KDIGO guidelines, which are nephrology guidelines, say that all patients that have acute kidney injury should be evaluated at 3 months for new onset and worsening CKD. That is an adult guideline. If I tried to follow up the kids in the NICU after 3 months after their acute kidney injury, I'd be going back to the NICU to do the follow-up. And so I don't think that 3 months is the right marker. Also for neonates, you have to remember that the developmental progression of their natural maturation of their kidney means that their adult GFR is not established until 2 years. And our estimating formulas for GFR are not validated in infants or in children less than 2 years of age anyway. So there's some real reasons for not seeing these kids super early. And then the AAP guidelines do give us a little bit of guidance saying that those with prematurity, low birth weight, or other neonatal complications should at least have their blood pressure screened earlier than the age of 3. And so I'm not sure that all general pediatricians are are doing that screening. And it's quite difficult to get a blood pressure on a 2-year-old in a clinic situation. So in 2013, we published this in a review article with some guidance for what constitutes higher risk individuals. But in my opinion, it's incredibly critical to make sure that communication happens between the NICU and the pediatrician to educate the families about healthy renal practices. And very simply, avoiding obesity, hypertension, smoking, and NSAIDs are 4 things that we do as nephrologists to reduce the burden of chronic kidney disease in all of our patient population. But I'd like to share with you what we're doing at UVA specifically. So we identify neonates with acute kidney injury stages 2 and 3, typically at discharge, and those infants are referred to nephrology, and I ask to see them at about a year corrected gestational age. And at a year, the only evaluation besides a good physical, reviewing their medical history and summarizing their acute kidney injury history and nephrotoxin burden is I do get a renal ultrasound, because kidney growth may be helpful in this patient population. And I have found that a lot of these kids have smaller unilateral hypoplasia, which may be a result of a renal artery injury or a vascular event, which I think is important to know from the beginning. Also, kidneys hypertrophy over time, and the most of what the kidney mass is tubules. And so if you have a low nephron number, your kidney is going to hypertrophy and can get into a normal range over time. That's why I want this renal ultrasound very early, before the kidney has potentially had time to compensate. At 2 years, I do a serum creatinine and a cystatin C to estimate their GFR, because again, the estimating formulas are not, have not been validated in less than 2 years of age. And at each visit, we check blood pressure, we educate on CKD prevention strategies, and I provide the PCP with the 95th percentile readings for blood pressure norms so that they can continue to monitor for high blood pressure. And then after 2 years, the follow-up is way more individualized. So if they have findings, a small kidney, high blood pressure, or abnormal GFRs, then we put them into sort of a CKD type follow-up. So now I'd like to spend the rest of the time talking a little bit about detection of chronic kidney disease and what we're doing in the lab to be able to expand the information needed to care for these kids. And so I'm going to talk just a little bit about a premature mouse model that my grad student, Ola Schvick, has been working on. This model was published back in 2012, where they delivered these mouse pups 1 to 2 days early prior to full-term gestation. Remember that I told you that mice get 4 days of postnatal nephrogenesis. So these animals were born basically 5 to 6 days before the end of nephrogenesis. And at 5 weeks, they did CKD studies on them to look at their number of nephrons, how much albumin in their urine they have, and blood pressure. And what they found is that these animals developed chronic kidney disease at a very early stage with lower nephron number and glomerular hypertrophy of glomeruli that they had. They had lower GFRs, higher blood pressures, and albuminuria. So this is a model of chronic kidney disease. So what my grad student Ola has been working on is defining more the early molecular and histologic signal that we see in the premature mouse animal to see if we can help understand what's happening in humans more fully. So we delivered these mice 2 days early, and then we euthanized them in the first week after birth. And the first finding that we found is that the nephrogenic zone, or that area where the self-renewing population of progenitor cells that keeps you having subsequent layers of glomeruli, was depleted a full day earlier in the premature mice. This may not seem like a lot, but that's estimated to be about 20% of your glomerular number being lost due to 1 day of early cessation of nephrogenesis. And we found that the glomerular density was higher in the term animals, here in blue, than in the preterm animals. We went on to do RNA-seq on the animals, on the kidneys of these animals at day 20. So the preterm group was 2 days old at that point, and the term group that was born at E20 was at postnatal day 0. And then we looked at them at 1 week. And in our unbiased analysis, basically throwing all of the genes into a crock pot to see what happened, the GOAT analysis that we did on these animals showed that the fat-soluble vitamin metabolic process was abnormal. And so if you look at these these genes to see what was upregulated and downregulated between the groups, you can see that there are 3 fat-soluble vitamin genes that are abnormal. This first one is for vitamin A. This is the retinol binding protein gene, encodes for retinol binding protein. And then CYP27B1 and CYP24 alpha-1 are both important in vitamin D metabolism, basically pushing you to a less activated vitamin D status. We also took a secondary approach to analyzing this data. We know a lot about renal development and the genes that are important. And so we took a candidate gene approach, basically categorizing all the genes into 30 different pathways or cell types that we thought might be important in the progression of CKD after premature birth. And again, we looked at these animals at day 20, which in the preterm group is 2 days old, and at day 27, which is a week of age. In our pathway analysis, or in this gene candidate approach, we found that at day 20, angiogenesis overall, the whole pathway, when we put all the genes together, was lower in the preterm group, versus, very surprisingly, this immune cell designation was higher in the preterm group at day 27. There were multiple other genes that met the criteria for significance, but these pathways were quite interesting. And then the last thing that we did is we took our bulk kidney RNA-seq data and performed a deconvolution approach on this bulk gene expression data and compared it to a publicly available single-cell RNA-seq data set from mice of the same strain that were at the same gestational age. And using that comparison, we were able to show estimated cell type proportions. And in this analysis, you can see that in the preterm group, their progenitor, their very early stem-like nephron progenitor cells were lower than the term group. The preterm group here is in the salmon pink color, and the teal color is the term group. However, what was surprising is that in a second group of progenitor cells, the preterm group was higher. And so when we investigated this second proportion of cells, we found that these were more differentiated cells. So what we think is happening is that these preterm animals are moving from a stem-like state to a differentiated cell earlier, probably representing explaining why nephrogenesis ends earlier in these patients. Also, the 2 other cell type proportions that were abnormal in the preterm group were the endothelium, represented here at 13, and the podocytes, the differentiated cell in the glomerulus that is very important in the glomerular filtration barrier. So how do we screen for CKD? You know, one of the big problems that I encountered in the beginning of starting my research was, you know, I wanted to understand about nephron number, we don't have good screening tools to give us surrogates for nephron number. I can't really tell what nephron number a patient has at birth or any time during their life in living individuals. Ultrasound, like I said, because kidney sizes correlate to tubules more, you can have compensatory hypertrophy in a normal kidney size that does not represent, that does not correlate with a low nephron number. There's a lot of variability in kidney biopsies. There's lots of heterogeneity, and so you can't, on a individual level really estimate well glomerular number from just a biopsy. And then kidney function doesn't really change until you've lost a lot of your nephrons. So with this in mind, or one more part of this is, how do we count nephrons? So I told you that those studies earlier with John Bertram and the other groups, they were very small numbers. The reason that is because counting nephrons is really hard. You have to have the kidney outside the body. You cut the kidney up into smaller and smaller and smaller chunks. And then you look at a small representative sample throughout the kidney and count those glomeruli and then estimate how many glomeruli are in the whole kidney. That's one way. That is called the fractionator dissector method, where you cut it up and you estimate from small samples that should represent the whole kidney. The second way is that you can digest the kidney. The kidney, the glomerulus and the tubule will separate under acid exposure. And so you can separate out the glomeruli from the tubules and then again estimate what glomerular number is by looking under the microscope and counting the glomeruli. However, these are both obviously very invasive ways of measuring nephron number and not able to do in a living individual. So the picture here is my collaborator, Kevin Bennett. Kevin and I have been working together. He is a biomedical engineer at WashU, and he and I have been working together since 2012. And he has been the brains behind all of the next work that I'm going to share with you on non-invasive ways of counting nephron number. So he developed a contrast agent that's based in ferritin. So we all know ferritin as physicians as the protein that carries around our iron so we don't get iron toxic. Ferritin is made up of 24 subunits with an iron core at the center. And so it has been, what Kevin did was functionalize it, and cationic ferritin has been used in lots of studies, especially in the kidney via investigation of the glomerular basement membrane using electron microscopy. The cationic ferritin is charged positively on the outside of the protein structure, and then we can inject it into various animals or kidneys, and it lands on the glomerular basement membrane as it did for those EM studies, except we give a high enough dose that with a very high field MRI scanner, we're able to see that iron core at the center of the ferritin, where it lands on the glomerular basement membrane, highlighting each functional or each perfused glomerulus. And so here you can see this is a human kidney that was not injected with cationic ferritin, and even at the highest field strength, you cannot tell the difference between the glomeruli and the tubules in this image. However, if you inject this kidney with cationic ferritin, it lands specifically in the glomerular basement membrane, and you can count each of these dots, which represent a glomerulus. So going back to Ola's project on the premature infants, we showed using cationic ferritin that her model of her premature mouse model showed that both in male and female animals, glomerular number was about 20% reduced in the preterm animals as it was in the term animals. And in this, in cationic ferritin enhanced MRI, we're able to see the whole kidney throughout without destroying it. And so instead of getting an estimate of glomerular number, we can actually get a full count of glomerular number. So I'm a pediatric nephrologist. I wanted to make sure that this would work in children. The glomerular basement membrane over time develops, and so would this work in a juvenile animal model? And so we developed a model of acute kidney injury in rabbits, where we gave these rabbits gentamicin and indomethacin, two nephrotoxins that are commonly used in the NICU. We gave it to these animals during a window of nephrogenesis, and then followed them for up to about 6 weeks. And at 6 weeks, we gave the animals cationic ferritin and euthanized them to take their kidneys out to scan the kidneys. So I want to show you just a video of, on a high field strength MRI scanner, this is a kidney that does not have cationic ferritin injected into the animal. And this is a kidney where each glomerulus is able to be visualized, counted, and measured. When we gave the indomethacin and gentamicin to the animals, we found this very unique lesion at 6 weeks. So as I told you, the glomeruli develop like rings on a tree. So the ureteric bud branches and induces a glomerulus at the end of each of those tips. And so you can count those layers of glomeruli. In the animal model of acute kidney injury where these animals got indomethacin and gentamicin, you can see this lack of glomeruli in this one ring on the tree. What's very interesting to me is that there are glomeruli distal to that lesion that still were able to form. And I think that this is because we only gave the injury for 4 days and they were still in a window of nephrogenesis to be able to come out of that and form some nephrons post the injury. You can see this injury on histologic examination, and we really reduced the glomerular number significantly with this injury of gent and indomethacin during nephrogenesis, although we had no change in the glomerular size. So these animals did not seem as if they were necessarily going through hypertrophy at this early time point that we examined them. So with that, I'm going to conclude. And preterm birth is common and associated with chronic kidney disease. There are unique exposures during nephrogenesis, such as hyperoxia and maybe hypoxia, along with nephrotoxic medications, inflammation, and the inherent immaturity of the proximal tubule that can reduce nephron number and maybe change vascular structure. The Neonatal Kidney Collaborative is an organization that is growing with a mission to protect the long-term kidney health of those neonates at risk with a multi-pronged approach. And long-term follow-up of these preterm kids really should occur, but it needs to be tailored and individualized until we have better data on who needs to be followed and when they need to be followed. And then lastly, cationic ferritin enhanced MRI is a powerful tool to detect in vivo glomerular number and size. And I didn't show in vivo, but we do have data now where we can put the whole animal after it's been injected with cationic ferritin into an MRI scanner and count glomeruli. So it's the first, we were the first group in the world to be able to count glomeruli in living, at least animals at this point. So I am going to stop there with a thank you to my team, my amazing collaborator, Kevin Bennett, our fantastic group here at UVA, my funding sources, and I'd be happy to take any questions.
Well, thank you very much. That was a fantastic overview of all things kidney in the NICU. So that was great. If anybody has any questions for Dr. Charlton, please put them in the chat. But I'll go ahead and start. You talked a little bit about the variability in measurement of creatinine in the NICU. And I mean, I certainly see that just between nephrologists and neonatologists. I would be happy to have labs every day, and the neonatologists really want to save every drop of blood they can. And I can see both sides. So
yeah, totally agree.
How often do you, do you think kids should have a creatinine? Should every baby in the NICU have a creatinine at some point? You know, that 29-weeker who's otherwise pretty healthy and doesn't get much attention, should they have a creatinine checked at some point?
So I'm going to say that we need to pause that for an official answer until we get data on data from standardized collections. So until we have the information across NICUs to be able to say what is the best, setup, I can't speak exactly yet. I will say that Arising, our study that is the prospective observational study, is dictating or requesting serum creatinines to be a standardization for the serum creatinine. There are some serum creatinines that our group has accepted as standard of care. And so the ones in that group are the high risk, but these are also high risk individuals. So the ones that our NICU colleagues have accepted as standard of care is in sick babies. And I can give you what those criteria we have delineated are, and that they get at least 3 creatinines in the first week. And then after that, it's more like weekly, but in the Arising study, what we're going to do is put a microscope on high risk events. And so what's never really been looked at is the timing of, the PDA and the indomethacin and acute kidney injury, the timing of the gent and the neck and the acute kidney injury. And so we need to get at it before all that stuff is happening to really see the temporal effect. So I think that until we have better data on well standardized collections, I can't speak yet. I will say that our NICU has been collecting lots of creatinines over time, and that's how I've been able to do some of the studies that we've done. And part of that is because not because they're collecting creatinine, but because they do their electrolytes in a panel that has the creatinine with it. And so we get away with it here with no extra blood, only because it's part of our panel. A lot of NICUs have gone to blood gas electrolytes, and there are ways to add in creatinine on those blood gases to be able to get, again, more data with less, with no more blood. And I completely agree. We're starting to do baby ninja here and monitoring for nephrotoxic exposure in our NICU. And that's exactly the pushback that we've been getting, is we don't want to give blood transfusions to these babies because we've been depleting them. So to come, I don't have exact answers for that yet.
And then one more question from Dr. Stepka, one of our neonatologists, asking about the definitions of AKI. So what is the creatinine cutoff for AKI, or how do you define AKI in a?
Yeah, so I didn't go through the multiple definitions that have been used throughout the literature, but currently, after that 2013 NIH workshop, at least participants in that group thought that the modified neonatal KDIGO criteria was the best definition to use at this point. And so I'm happy to send that out, but it's in all of our Awaken publications as to its a change in serum creatinine of 0.3 within 48 hours, or hitting one of 3 changes from baseline. So over 150%, 200%, or 300% are the changes. But it makes it really challenging when you have a baby that comes in. I mean, good gracious, I had 25-week twins a couple years ago that mom was on dialysis. And so imagine what their creatinine is when they start life. I mean, that's an extreme example, but a lot of these babies either have some placental insufficiency, or mom may have a little bit of kidney disease. And so they have higher creatinines to begin with. And so they're trying to find their steady state. So the answer to that is we use the modified neonatal KDIGO criteria at this point. But there has been, out of the Awaken data set, one paper on redefining AKI. And there is a lot of work that we're putting into to collect the right data to be able to do this out of the Arising data. Again, it all depends on, your definition has to be based on a standardized set of creatinine collections. It's really hard to develop a definition when you don't have all the data available, maybe missing pieces. So we're working on that actively. The other part of the definition of acute kidney injury is that we have always, in adult studies, in pediatric studies, used its association with mortality and length of stay. But is that really the right way to define acute kidney injury? it makes it a little challenging. And what we've been challenged by the writing of Arising has been, should we be looking more at kidney outcomes, not necessarily mortality and length of stay or short-term outcomes in the NICU? And that makes a lot of sense. But as the nephrologists know, just because you don't have CKD at the age of 2 doesn't mean you're not going to have CKD at the age of 10 or at the age of 20. And that's the really hard part about pinning our definition to long-term kidney outcomes, is that that is a moving target.
Well, thank you very much. Thanks to everybody for coming this morning, and let's go prevent some kidney disease.
Thank you very much for having me. And if anybody has questions, send my email out.
Great.
Thank you.
Bye-bye.
Bye.